Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and once again I have to say I'm so grateful to have the chance to use this platform and have the honor to have so many amazing lecturers and educators from around the world accepting the invitation and joining us from this platform. And today I have a very, very dear friend, a master clinician, surgical prosthodontist, educator, lecturer, mentor, consultant, innovator, author, and what can I say? Great friend, Dr. Scott Ganz is here with me on Hot Seat. Hello, Scott, and welcome to Hot Seat, my friend.
I'm very happy to be here. It's wonderful to see you, even though we're a little bit further away remotely. I certainly miss all the good times that we spent together.
Yeah, me too, my friend. As I said, I have to say, Dr. Ganz really doesn't need any introduction. He's truly a master clinician, and me personally learned a lot from him. I'm pretty sure so many of you, at least for one time, you've been uh, at his presentations, and me personally had the chance to also be in a travel with him. We've been to India, to Africa, to Netherlands, and so many other places. So for me, he's one of my mentors and idols. And really, the way that he explains over the years the concepts for dentists around the world is unique. And I have to say, he's really, really one of the pioneers in providing dentists, especially in the field of implantology, how to make a proper diagnosis and treatment planning for the patient, especially relying on uh, digital technology, cone beam CT technology, and lots more. And the topic that he will present for us today is decision making and diagnosis and treatment planning protocols from single tooth to full arch rehabilitation. So it will be so much fun and so many things to learn and be updated. But before we start, as a tradition of Hot Seat series, I would like to have Dr. Ganz' CV for all of you. As I said, he really doesn't need any introduction, but as a tradition, I would like to have his CV for all of you, and then we will go to the presentation, and at the end, we will have a good discussion on the topic. Dr. Scott Ganz graduated from New Jersey Dental School, now Rogers School of Dental Medicine. He then completed a 3-year specialty program in maxillofacial prosthetics at MD Anderson Cancer Center in Houston, Texas. Dr. Ganz is well published in various scientific and professional journals and contributed to 14 scientific textbooks and delivers presentations globally on the prosthetic and surgical phases of implant dentistry and three-dimensional imaging technologies. He is considered one of the world's leading experts in the field of computer utilization for diagnostic, CBCT, treatment planning application software, and CAD/CAM technology. He has been a featured speaker for numerous organizations, including Academy of Osseointegration, ICOI, American Academy of Implant Dentistry, EAO, and so much more, and serves as editor-in-chief for Cone Beam International Magazine of Cone Beam Dentistry and the associate editor of Implant Dentistry, also other things to mention. Dr. Ganz' book, An Illustrated Guide to Understand Dental Implants, available in both English and Spanish, and has received wide acclaim as the standard in patient education text. He is presently on staff of Hackensack University Medical Center and at Rogers School of Dental Medicine, Department of Restorative Dentistry, and has served as an industry consultant for dental implant, imaging, and high technology arena for the past 28 years. Dr. Ganz is a past president of the New Jersey section of the ACP, past president of Computer-Aided Implantology Academy, and currently the co-director of Advanced Implant Education, providing hands-on live surgical programs in the United States and international venues. Dr. Ganz maintains a private practice for prosthodontics, maxillofacial prosthetics, and implant dentistry in Fort Lee, New Jersey. Once again, it's my absolute pleasure and honor to welcome you, Scott, and really looking forward for your amazing presentation today.
Thank you, Omid. It's really my pleasure to be here, and I appreciate not only our friendship, but all of the knowledge that you have imparted to many people under this platform and all of the other wonderful opportunities that you have provided for education. You are also a master clinician and also a master educator, and it warms my heart to see your travels around the world when we were traveling, and hopefully we will be able to do that again sometime soon.
Sure, thank you so much.
So you want me to share my screen?
Share your screen now.
Okay, we seeing that?
Yeah, perfect.
Okay, Omid. So I always like to start out all of my presentations with an underlying philosophy, and that philosophy is that there is a danger when we are bound by two-dimensional concepts when clearly we live in the three-dimensional world. And so, from dental school through post-grad, through wherever you are today in your career, we've changed, moved from an analog to a digital world. But more than that, we've also had to think much differently because we truly have technology that allows us to be able to think in three dimensions, and hopefully that we're not going to be stuck in a two-dimensional world, and hopefully I'll be able to explain those concepts during this brief presentation. And so as we start to move forward with our educational process, there are many textbooks, as Omid had mentioned. It's over 15 textbooks now. The one that I highly recommend is this one here in green, which is the second edition of Dental Implant Complications, Etiology, Prevention, and Treatment by Stu Fromm. I think it's a wonderful book to have in your library, amongst many others. And, as an oral surgeon, Fonseca, oral surgery and maxillofacial surgery, I was very, very honored to be part of that textbook, and many, many others. Peterson's Principles of Oral and Maxillofacial Surgery, Dr. Keratu, my dear friend, Dwayne, Implant Aesthetics, his recent book, Michael Sonic's book on soft tissue development, Dan Cullen's book on minimally invasive dental implant surgery. These are all wonderful, wonderful textbooks to add to your library, and I hope that many of the concepts that I will share with you today are represented in those chapters that I've contributed, as well as some of the amazing work by these clinicians that have dedicated their lives really to educating people on these techniques and modalities. I'm most proud of our combined textbook with Dr. Marco Rinaldi and Angelo Motolo, our computer-guided applications for dental implants, bone grafting, and reconstructive surgery. This has been now in, I think, 3 or 4 different languages, and it's become a standard textbook for some of these procedures, even though it's been now around for more than 5 years. And as Omid mentioned, I am the editor-in-chief. Cone Beam has now changed their name to just Digital. And so it's now called the Digital International Magazine of Digital Dentistry, which combines both CAD-CAM and Cone Beam CT. And so when we start to understand the movement from analog to digital, when it comes to dental implants, when it comes to oral surgery procedures, it's really been an interesting road over the last 35 years that I've been involved with 3D imaging. And the basis for almost everything that we will talk about is Cone Beam CT today. And there is no better tool to be able to assess our patient's anatomy. And we'll go into that in much more detail. And so, of course, I could not start this, Omid, without sharing some of these wonderful times that we had together. Here are some pictures from Africa, from the Netherlands, from, I think, Las Vegas, and of course, the ever elusive black rhino, which we're still searching for. So hopefully we will have those experiences once again. It's really, I have to also say that, Omid is able to take the best selfies of anybody that I know, because he's got the longest arms of anybody that I know. So the concepts we'll try to talk about today are the essential technologies, diagnosis and treatment planning, restoratively driven planning, which is really the foundation for my philosophy, the merging of the data sets, both cone beam CT and intraoral scans and more, fabrication of surgical guides, not just for implants, but for many, many other things. If we have time, we'll talk about guided PET partial extraction therapy, which I know you've had wonderful lecture by Howie Gluckman and some others, but also for guided sinuses and guided harvest grafting for taking bone, let's say from the ramus or the symphysis, and then full arch restorations. So all of this technology comes together, but the basis for my philosophy is going to be that the goal of implant dentistry is, it's not the implant. It's not the implants that we place. Our patients come to us because they need teeth. And of course, the goal then is the tooth that we replace. And so we have to have the mindset that dentistry, conventional dentistry, is part of what we do with implant dentistry, because the end goal, of course, is to replace the patient's teeth, not to place implants. Implants are only the road to that successful outcome. I cannot do implant dentistry without today. The first, obviously, is going to be that foundational imaging modality, cone beam CT. And the second one, though, may not be as come to your mind immediately, but that is resonance frequency analysis and ISQ, implant stability quotient. And so I will try to explain those and why that's so important as we move through this presentation. Patient comes in, as an example here, with a fractured central incisor in the lower arch, 84 years old. And we gave her several different options. And you can see from the x-ray that there's not a lot that can be done in terms of maybe creating a multi-unit support or bridge. So when we think about perhaps going to an implant, and by the way, age really is not a deterrent for what we do today with implant dentistry. And I think Omid would agree that our healing does not really change as we get over. In fact, and older. In fact, I think many of my older patients heal better than some of my younger patients. And so we gave this patient several options, and because we had done implants on her before, and because she had been, trusting our opinion, she said, "Okay, sure, go ahead, place an implant." When you're going to do this, we have different modalities of treatment today to be able to assess that anatomy. Now you can see the fracture and also the potential other teeth surrounding this tooth will also potentially fracture and are not necessarily strong teeth. But in an 84-year-old woman, I think it would be, a simple, concept to be able to place an implant. And then we get the wonderful illustration of the difference between the trajectory of the tooth and the trajectory of the bone when we use cone beam CT. And here's a clear illustration of the tooth being at an angulation which is going to be different than the angulation of the bone itself, which we would have the potential for causing iatrogenic damage or complications if we didn't have this view, this cross-sectional view. We can also look at the density. If we look at the variable opacities of the objects that we see here, we can see that this may or may not be the most dense area to place an implant, even though it's in the symphysis area. So we have these myths and realities in terms of, how dense that bone is in the anterior symphysis. And it's not always as dense as it appears. And so we have to look at the thickness and the opacity of that cortical plate, both on the buccal and the lingual, that helps us to determine, what kind of loading we want to utilize, not just about the buccal and lingual cortical plates, but also the intermedullary bone, which you can just use your eyes and you can see is not that dense. When you look at the inferior border of this mandible, we can see that we have some dense bone way back there, but we don't have 30 millimeter implant that we're going to place in this area. And so once we start to evaluate this and we look at the trajectory of the tooth versus the trajectory of the alveolus, we have to have this image in our mind in terms of where we want to place the implant, whether we're going to have a screw retained restoration or a cement retained restoration. And so this is the diagnosis and treatment planning phase that becomes critical to understanding where implants should be placed, if they can be placed, and how to avoid potential complications. As you can see by the illustration here, there's very little uh, root of the tooth sitting in the bone. And so we have literally lots of bone height to place an implant if we wanted to. And then we have to decide screw retained or cement retained restoration. And this is all should be decided before we touch the scalpel to the patient. And when we're starting to look at the 3D imaging, there's a lot of scatter that occurs, and we have to go through a process called segmentation. And this is really not a great example of that, but it's good enough to look at the adjacent roots. So we have to adjust the density value in the cone beam CT software to visualize the roots on either side, and we can then understand where we can position that implant. So we look at people like my dear friend Dr. Dennis Tarnow, who talks about and Maurice Salama and many of the others that coined the concept about implant to tooth positioning. But that was all done before CT and cone beam CT. They were all based on two-dimensional measurements and two-dimensional imaging. And so here we have to look at the proximity of that implant next to the roots, but the PDL space of the adjacent teeth. And then we have our choice. Are we going to do this freehand or are we going to do it with surgical guides? And in this case, because we were going to do this for this 84-year-old woman who had limited finances, and we wanted to do it, quickly, based upon all of this information, based upon all of our measurements and our skill, we know that we can do this in what we've termed as diagnostic freehand surgery, and this described in detail in our textbook as well as many of the other articles in the literature. So as part of our Ganz-Rinaldi classification of guided implant surgical protocols, this is diagnostic freehand based upon cone beam CT, based upon the three-dimensional imaging and the measurements that we have available to us through the software that we interact with. And then once the implant is placed, and here you can see the healed result after 8 weeks, we did an immediate restoration on this. I'm not going to spend that much time on each for this in this presentation going through every step. But what you can see here is tissue has started to mature. We're using a smart peg, which is part of the technology from Ostel Technology, and in combination, in this case, with the Megagen Corporation, who provided the implant, and we can measure the implant stability quotient through resonance frequency analysis. And then we can determine what is happening to that integration process over time. And our final restoration in this case will be a screw retained restoration. And you can see that the screw access hole comes directly through the middle of the tooth. And that's where we want this to occur, through the envelope of the tooth. And we have a very good result for this particular patient. Now, this is, again, we're not trying to correct everything in her mouth. We just wanted to get her a tooth, which we accomplished the same day that we extracted the tooth. And now we have a long-term permanent result for this patient that will be, I hope, last beyond her lifetime. And you can see the proximity to the roots. We had room for this implant, and we were able to do that with our understanding of the patient's anatomy. Without cone beam CT, I do not think that I think we would be taking chances based upon the trajectory of the tooth versus the trajectory of the bone. So that's your basic concept. Implant stability quotient, implant ISQ, is an objective measurement of implant stability. In other words, we're looking at understanding how that implant is behaving in that bone. And we use it with scientific measurements where over 1,100 articles in the literature are supporting this technology, which is why I will not load an implant without knowing what the ISQ value is. And oftentimes we take multiple measurements during the lifespan of that implant. So we can see what is happening the day we place it. We can see what's happening the day we uncover it. We can see what happens, 2 or 3 years later if we want. We have the ability to assess in an objective manner the stability of that implant within the bone. And so as you can see here, we have two implants, one with a healing collar. The healing collar is removed. This is during the transitional loading phase. We're going to take measurements on each one of them, and we record that in the patient's chart. We record that as a medical legal entry so that, if anything happens, or if we want to say, I loaded that because I had a 78 ISQ or an 82 ISQ, I was well within the boundaries of what the research says. If that implant does fail, at least I did everything I could. And even in the situation here, as you can see with a partial extraction therapy case, we want to take that measurement so we understand whether or not we should place a healing collar on this, whether we should make a temporary restoration. This gives us objective data, which is much different than insertion torque, which we can talk about later. And so it doesn't matter where the implants are located, how many implants are done. We do this all the time. This is the Ostel IDX unit. And so many years ago, I came up with this phrase, do you ISQ? And I hope that everyone will. And this is the original Megagen unit, which is now replaced by the Meg ISQ2, which I showed a picture of earlier. And so as the digital world changes, we are changing what we do. It's a behavior change in our everyday practice. And sometimes, we want to use technology, but we don't know how to use technology, or we make mistakes with technology. So as you can see here, this is a cone beam CT that was sent to me for an evaluation for a lower full arch case. And one of the problems here is patient positioning. So as you can see, as we start to segment and separate the upper and the lower jaws, you can see where the two mental foramens are, but about 40% of the mandible has been cut off because it wasn't captured in the image by the cone beam CT. So this was poor patient positioning. So it does not allow us to have the information that we truly need to be able to assess the patient's anatomy. Now, this was an interesting case. This was a patient that was referred to me for an all-on-X type of restoration. And what you can see here is pretty straightforward. We can extract those teeth. We can probably put some implants there. The question is, can we do this in a guided fashion? And so when we start to look a little bit more closely, we want to see where the mental foramens are. But here's an instance where we have to evaluate. And by the way, with whatever the software you're using, this happens to be Blue Sky Plan software. I think it's one of the most powerful software available, and it's totally free, which makes it so attractive for everyone to use. Always, my go-to concept here, always redraw the panoramic curve, because that's where all of this information is based upon. And Omid, I want you to take a close look at this, as well as everybody watching, because this is an interesting presentation. When we visualize this patient's mandible and we think about doing a guided case, let's say with fixation pins, anchor pins, and a template, we're now seeing another part of the patient's anatomy that probably wasn't there when she was born, and that is a very large silicone chin implant, which almost went from ear to ear on this. And so certainly we cannot think about trying to put anchor pins on the facial or the buccal aspect. And you can see it here as we blow this up, the gray area on the outer part of the buccal plate, that is a silicone chin implant. So did this patient note this on her intake history? No, she didn't do that. So the cone beam CT told us, yeah, that is present and that is there. And so that would help us to avoid complications. In the US, we have a specialty of the American Academy of Oral Maxillofacial Radiology. The the specialty of the American Dental Association, and I was very, very proud and honored to be part of their position paper on the use of cone beam CT technology for implants. And this is already 8 years old. And back then they said in 2012 that the AAOMR recommends that cross-sectional imaging be used for the assessment of all dental implant sites, and that cone beam CT is the imaging method of choice. Now, we say this like, okay, well, we should think it's standard of care, but the reality is it's still state of the art. It's definitely not standard of care everywhere in the world, even here in the US. And unfortunately, there are many people that are still using two-dimensional radiography. And so I've been talking about this for many, many, many years. And, as we talk to our children in the car when we're on a long trip, they're always saying, are we there yet? And that's the question that people are asking me, are we there yet? Can we go totally digital? Do we need any analog information? And the reality is, absolutely we can, but the vast, vast, vast majority, we're talking 99.9% of the time, we should incorporate both an analog and a digital component to our planning. And unless you're really incredibly well equipped and you have a tremendous staff and training and the dental technicians, it's very, very difficult to do everything digital. But we are working up to that. And so when we think about the road here of going from analog to digital with three-dimensional imaging, I mean, this is my wife, likes me to throw things out, and I go into my archives in my office, and here's a user manual from 1994. So think about how many years ago. This was Simplant version 1.1, which is, I contributed to the development of this program. This is 26 years ago, and I'm still talking about the same exact information that we had way back when. And I was very honored to just recently been asked to speak at the AAID, their virtual experience, only about 2 weeks ago. And as we travel around the world, you'll notice in the back of this picture, and you'll see the cone beam CT image will always, we will not do surgery even on any of our live training courses around the world. Everything is computer guided. And whether you do it freehand or not, the computer has to be there as an aid to helping you diagnose and treatment plan better. So I talked about segmentation. So here's a kind of funny way to talk about segmentation. When dogs are, oftentimes are put to sleep to have their teeth cleaned or for extractions, and they sometimes, in cases like this where they took a cone beam CT, we can utilize this technology to segment, meaning we're going to use the density values to separate the soft tissue from the hard tissue. And here you can see the tube that intubates. We can see the bone. We can see the teeth. We can see where the tongue is for this dog. And so we have the tools to do this for all of our human patients. And certainly that is the hallmark of being able to plan with great accuracy and consistency. And so if you talk to any dental laboratory around the world, they all face the same problem. They're getting cases like this all the time. And many years ago, I coined the phrase prosthetic gymnastics. And prosthetic gymnastics, means that the laboratory technician is going to have to take an implant that's located over here and fix a tooth that's located over here, and it becomes literally gymnastics. And we want to avoid that complication. It's hard to believe that the same clinician placed this implant, one on the right side and one on the left side. And so, we have to understand that complications can occur. Our job is to avoid the complications using the tools that we can. And that's why I came up with a concept many years ago now called brain-guided implant dentistry, or brain-guided implantology. And you may have heard me talk about that or seen that on social media. And basically, here's one of the articles about brain-guided implant reconstruction. Who makes the decisions? Because a lot of people think that it's the computer that makes the decision. And that's why they don't believe that they need to have this technology. But the reality is that we're using the computer to enhance our ability to make better decisions. And so if we take a look back at one of my dear friends and incredible educators, Dr. Joseph Kahn. He classified the anterior maxilla in terms of the root position. And this is a really wonderful, wonderful article that shows the difference in anatomy and the position of those roots. And when we, especially when we're looking at, a wonderful presentation like that Howie Gluckman had done, where we're talking about, socket shield and partial extraction therapy, you need to assess that trajectory of the tooth versus the trajectory of the root, as I explained earlier. And so when we do that, however, we have to then think about if we're going to extract the tooth, place an implant. The concept I talked about back in published in 1995, the triangle of bone, this area identifies the most volume of bone that an implant can be placed in. And if we bisect that triangle, the implant will be placed within the most volume of bone. But that may not be the proper position for a screw retained restoration. For a cement retained restoration, yes. And so we have to evaluate each clinical presentation in its three-dimensional picture. So as you can see here, there's almost no root sitting in this alveolus. And if we think about placing an implant into this area, we have to be able to think, well, if I place it like this, even if I use the, let's say, an osteodensification, and we try or we try to split the bone and have a ridge splitting concept, we still would have to place the implant basically in this position, which would end up being a cement retained restoration, or we would graft this area, and that would allow us to be able to move the implant into a different position so we can have a screw retained result. So this would be a cement retained result. I don't know where that came from. We're still going, right? Okay. So when we look at the next example here, we see again the root sitting in a more beefy type alveolus, and now we have more bone to work with. So again, we can position the implant within that triangle bone concept. However, when we're thinking about doing a screw retained restoration, we would take that information and we would move that implant so that the yellow projection is coming out now through the lingual part of the tooth. And we can also then slightly move the implant towards the palate in this case to position it so we can do a screw retained restoration. So what this represents is that we're the engineers and the architects of the oral cavity, and we can, in fact, be able to plan these cases to tremendous accuracy and tremendous consistency, especially if we're doing it as a guided case, which, of course, all of this allows us to do simulation, and that simulation helps us to learn and increase our ability. And so when we're looking at these types of restorations, like as you see here, the tooth sitting on its root, or here in an analog, we should have really no understanding of whether this was done as a screw retained or cement retained design until we look a little more carefully. And again, here's a screw access hole coming directly through the envelope of the tooth, gives us much more retrievability, and you would have the correct emergence profile and the correct position for this type of restoration and long-term maintenance of the interproximal height of bone, and of course the surrounding soft tissue. So when we think about doing screw retained or cementable, we have to be basing it upon both the art and the science of 3D imaging applications, which is really taking your own experiences, looking at the ability within the technology that we have and the equipment that we have to be able to do these types of cases. So as we described in our classification, there's three different methods that are based upon cone beam CT for doing implants. One is diagnostic freehand, which I gave you an example of, template assisted, and then full template guidance. And so in order to be able to accomplish this, and all three of them, we need the cooperation of the dental laboratory technicians that work with us that help plan these cases in many cases, as well as, of course, the implant manufacturers to provide us with the necessary drills, the necessary components to make it possible, as I will explain. And so this is the classification in our textbook. Diagnostic freehand, as I said before, we're going to take all of our measurements. We're going to take those measurements, we're going to visualize and determine whether or not an implant receptor site is okay to place an implant. And if it is, we can go in and we can place the implant freehand. Template assisted is where we're going to create a template. And that template is going to guide the trajectory. It's going to guide the depth, in many cases, of the position of the implant through your osteotomy creation. Full template guidance, however, is another story. We're going to not only drill the osteotomies with the drill guide or the template, but we're going to place the implants through the guide using our special carriers that allow us to be able to accurately place the implant, engage the walls of our drill guide, and then position the implant within the osteotomy. Because as we know, especially in the maxilla, the bone can be soft, and when we drill the osteotomy, we can still move the implant out of the position with too much force or not angling the implant properly as we position it. So full template guidance gives us total control over the placement and I believe, the most accurate way that we can do implants today. And even here's my partner in crime, Dr. Isaac Towell, in our advanced implant education, and we're incorporating in our live cert courses dynamic navigation. Now, dynamic navigation is without a static guide, but this is still a template. But this template I call a virtual template. And this virtual template is locked into the computer, and this is what we base our surgical skills on. And so having dynamic navigation is one of the next generation of where we're going with our guided surgery applications. And this is very, very exciting. And so in order to be able to plan our cases properly, we can't utilize cone beam CT by itself in all cases, especially, let's say, a single tooth like this when we want to use a guide, because the surface representation of that data is not good enough to position a surgical guide. We need the surface of the intraoral scan or a stone cast that we digitized with a desktop scanner to be superimposed upon the cone beam CT data, and then we can fabricate a surgical guide that will fit accurately when we have a tooth-borne situation. And even when we're doing other advanced cases, we still are going to do the same thing. So here's an article I was involved with my dear friend and oral surgeon in Hawaii, Dr. Cameron Lee, on the use of cone beam computed tomography with intraoral scans. And this, again, this was back about 8 years ago. And so we have the ability to be able to do these types of cases. Now, here's a case I'd like to share that was done by my dear friend, Dr. Gilbert Tremblay in Canada, using a precursor, if you will, to where we're going with stackable type guides and the bone reduction concept that I developed way back in the early 2000s. And so here we have a patient that's going to come in that's going to require a full arch restoration. And I was very, very, very honored in May of 2019 to have been honored by the American Academy of Implant Dentistry, the AAID, and I actually received my award in Montreal from Gilbert Tremblay, which was a great honor for me. And so when we have the ability to assess a case like this, I mean, how do you know where the place the implants based upon this crazy mix mash of teeth that are going in all different directions? So we need to always focus on the end result first. And in order to do that, in this case, a panoramic radiograph gives us a scout idea of the type of bone and tooth positions that we have. But now we're going to take the digital technology and go one step further. We're going to create a smile design with the software that's available, and be able to design the restorations in advance of doing the surgery. Again, now we're combining digital technology to look at before and after. which means what? Which means that we are restoratively driven. We're looking at the final result before we ever touch the scalpel to the patient. I have a very difficult case I'm working up right now that's supposed to be done on Saturday, and the bite is not right, the occlusion is not right. It's so difficult to then determine where exactly we're going to position the teeth, and that means that we're going to position the implants based upon the desired final result. And so we can use our conventional wisdom of the golden triangle, the golden set of proportions, I'm sorry, and we can fabricate the length and the positioning of these teeth. And then from there, we will position our implants and understand whether we need angled abutments or straight abutments for the restoration. And I take just as much time planning the fixation or the anchor pins as you see here in the color to be able to um, understand where they can go to maximize when we're the stability of our templates. And so now we're going to merge the intraoral scan data, the smile design data with our cone beam CT data. We're going to create a stackable type of guide system, or interchangeable guide system, I should say, where we can visualize and put even the features and overlay this, overlay the smile design, look at the treatment planning concept where we're going to do bone reduction. We're going to have a static guide. We're going to fixate that static guide. We're going to know exactly the angulation of the implants that we need, where the multi-unit abutments will need to go. And this is where we combine all of the technologies together. And so when we have that ability to do that, extract the teeth, we place our bone reduction guide. In this case, piezo surgery was also used. And this was the original article that I published in 2006. And we started developing this concept of the bone reduction guide back in 2002. And it was difficult to get the software companies to be able to do this for us. But again, this was back in 2002 when we developed this. And I came up with this concept using stereolithography, 3D printing. And today we can do this in our office. And we do this routinely in our office. And so we've come a long way in the last 20 years to where we have the ability to design and print these templates in-house. So here you see the guide, the anchor a very, very accurate way of creating the osteotomies. And we can see here that there's defects in the bone, so we're going to have to fill those defects. And then we register the prosthesis, the immediate temporary prosthesis, we register it with our stackable type guide, as you see here. And this allows us to place a CAD/CAM immediate fixed prosthesis to these implants after their ISQ values have been assessed. And you can see it right there. And again, these are the precursors to what we now call a scallop guide, which is another story entirely. And here we can see the pickup process with our titanium sleeves and screws, and the patient walks out with a restoration that's very acceptable. And so this was published in 2018. And so what this does for us, it gives us a tremendous power to be able to diagnose, to be able to then treatment plan, to be able to communicate that treatment plan with all members of the team, which of course include our dental laboratory technicians, who we can't do this without, or the oral surgeon, if you're doing it in two different offices or maybe the same office, and you want to communicate everything. And of course, communicating to the patient, and then it allows us to execute that plan. And so having all of this information is what allows us to be able to get to the end result time and time again. But there is one caveat, and that's my personal opinion, that the concept of guided surgery is actually flawed in one aspect. As Omid may know, I say this all the time, that you put two dentists in a room, you get at least three different opinions. And that's one of the problems, is that we have a lack of agreement on where we should place the implant within a given receptor site, because everyone has their own personal preferences. But if we have the foundation of cone beam CT and interactive treatment planning software, we have all of that information to be able to get to that final result. Whether you're doing a full arch or you're doing, let's say here, we're going to replace a long span area with implants, we have to be able to have the ability to know where the nerve is, to be able to again, we always redraw the curve in these areas. We have to now draw the nerve to be able to make sure that we are not violating any of the local anatomy or adjacent vital structures. And it's very, very important whether we're doing an implant here or we're taking bone from the ramus. These are the important keys that help us to be able to evaluate the type of bone, the type of density, and of course, the position of the implants. And so as we start to have that information, we will have an intraoral scan. We will then merge that intraoral scan with the cone beam CT data. So that will help us to be able to finalize our plan and create a surgical guide. Now we know that there's three different main types of plates today: the tooth-borne template, a bone-borne template, and a mucosal-borne templates. But can we also create guides for other procedures as well? And of course we can, whether it's with implants or whether we're going to go beyond. And so let's see if this, so here we are placing our implants in this area here, but placing the implants in the bone without knowing where the teeth are, it doesn't give us the best accuracy for being able to ascertain the patient's occlusion, the patient's screw access hole through the envelope of the teeth. It's where we have to either have a digital wax up that's virtual, or we have to do a physical wax up and then scan that so that we now know where we're going to place these teeth, where we're going to place the implants, and we can then have a final outcome where we are going the angulation of the implants to be within the body of the teeth, and then we can create our surgical guide, and that surgical guide can be utilized for our surgical intervention. So all of this is based upon understanding of how we utilize the technology. Here you see we're taking that template because now, for those of you who want to design their own guides, this is the process. We're first designing the guide, and then we're creating the windows. And the windows are very important because the windows are there to be able to make sure that this surgical guide is fully seated as a tooth-borne guide. And so as you'll see here, the windows show up so we can see the teeth through the guide, and that makes sure that we have the intimate contact that we need. Otherwise, the template may not be seated properly. We can also make these implants perfectly parallel if we want. We can create the abutments that go on top of the implants so we know exactly how much angulation we have. And then we have to match the drills from the manufacturer to match the design of the template. And so all of these ingredients have to come together in order to have success. And so as we start to move forward through these processes, we have to do this for the mandible, for the maxilla. It doesn't matter. It's the same exact concept to be able to position the implant virtually, to be able to do it with the collaboration and the merging of the STL files. You can see here that we're placing the implant, and now we're going to take a 360-degree rotation around the implant so we can make sure that that implant is not going to bump into the adjacent root if that tooth is going to stay. And we can look at the PDL space, and we can evaluate implant to tooth relationship. It's really implant to root relationship in order to be able to have the kind of safety zone. So we're merging that intraoral scan. We can see now as we separate this with our thresholding, the position of that implant versus the position of the root. And that is where we truly gain our accuracy with our tools that we have today. So one of the cases that I just recently did and presented, when we have a case like this, where we're going to extract these teeth, and we're going to place implants, you know, you don't have to necessarily, if you extract all of these teeth and then try to do it freehand, you lose your perspective of where you are. And so we can look at placing, let's say, 6 implants, but would I place all 6 implants at the same time? Or perhaps maybe we're going to do things a little differently, because if we can see here on the left-hand side of the screen, the implant in the number 4 position is going to require a lot of bone grafting, and those little blue dots. If we look at the implant in the number 5 position, we have enough bone height. We don't have a lot of bone width, and the density is not that great. And so as we start to look at each one of these, we may realize that this has to be a staged approach. So we're going to merge the intraoral scan. We can then see clearly the position of those teeth, and we can visualize that within the envelope of the cross-sectional image, which you can see one of the malpositioned teeth is outlined in the magenta color. And we can see in the upper left, number 13 in the US designation, is going to have an implant in that area, and it's completely different than the actual position of the tooth. And so what we're going to do here is we're going to do a segmented segmentation of the actual intraoral scan. In other words, we're going to extract the teeth virtually on this intraoral scan model of the maxilla, and we're going to look at placing these implants and where they're going to come out. We can visualize all of this. We can extract these teeth. We can do advanced segmentation to see where these roots are. And then instead of extracting all of the teeth at the same time, what we're going to end up doing, and here we can see the selective transparency. Again, it's another term that I've coined in the literature to show how we can change the different density values. And once we do that, we can visualize all of the placement. But what I decided to do is that there's only a couple of sites that we can actually place the implants. So instead of extracting all the teeth, we're going to extract just some of the teeth, and then we're going to place implants where we can, and then we're going to use those teeth and we're going to grind them up using the smart dentin grinder. And if you don't know about that technology, you need to learn about it, because it is really a game changer. We can get so much autologous material from our patient's own cells, in this case their own teeth, that it is, you know, why go to a bone graft from a bottle when you can have this much volume from our patient's own teeth. And so we're going to go in, we're going to place only 3 implants or 4 implants in this case, and then we're going to extract the rest of the teeth. We're going to use all of our grafting material that we created. We had so much volume from the patient's own teeth that we couldn't even use it all. And so here you can see that we're filling the sockets, we're filling the area. We're going to then fill all of the defects, and we're going to come back in 4 or 5 months, and we'll place the rest of the implants and then use these to help guide the final restoration. But look at the amount of volume of bone that we're able to get by using the autologous grafting material. So, Omid, I'm going to show one more case if we have time. Is that okay?
It's okay. We have time.
Okay. So now when we get to a full arch immediate restoration with what I call the state of the art in our guided surgery armamentarium, this is truly a wonderful innovation of utilizing stackable guides. And so this takes an interesting approach. We have teeth that are present that are all going to be extracted. We actually use the teeth themselves to register the position of our fixation base, which is going to be the base that will hold all of the stackable components. And this is truly a remarkable innovation that we have here. So if we take a look at the pre-op cone beam CT, again, we're going to follow all of the same steps of merging the data sets, and then we're going to create, using a program like exocad or 3Shape, we'll create our STL diagnostic wax up. We'll put everything together. We can see the blue outline of the proposed teeth. We can see our triangle of bone, and we're going to then plan the position of all of these implants utilizing our diagnostic wax up that's now completely digital. And these are all of the different components that we will use to be able to complete this case. These are the components that we show for our hands-on workshops on the right-hand side, and on the left-hand side is exactly what we use in a real clinical case. And so here, we haven't really been doing too many of these live courses, but we do provide this type of training because you really have to try it once to be able to truly understand how all of these parts and pieces come together. And so here is our pin guided pin guide. I'm seated over the teeth after the tissue has been reflected. And now you can see that there are going to be fixation pins that will stabilize this. The pin guide will be removed, and the metal, this is a metal guide, it's called guided smile chrome, will be then fixated onto the buccal surface, and only the buccal surface. This does not go to the lingual or the palatal surface. So the pin guide is what stabilizes this. And here you can see on our hands-on model exactly kind of what it looks like. It actually does not touch the bone. It hovers off of the bone in this manner so that it doesn't have to engage in any undercuts and cause any issues when we're dealing with the extraction of the teeth. Once we have that, we manage the soft tissue, we extract all of the teeth, and then we have to go to the next step, which again is going to be our bone reduction. And there are many ways of being able to do that. Here we're doing the freehand bone reduction with on a straight handpiece with a large burr. And this is one way to do that. I prefer using both piezo surgery and using this type of burr to be able to smooth the bone. The problem is you have to watch your angulation because you can easily create the different platform than you intended if you angle your drill in the wrong position. So you really have to be cognizant of that because you don't have, in this case, a lingual set of references to guide you. And so sometimes you could, mistakenly take too much bone off. Sometimes you take too little bone off, and that's where you have to put this carrier on and you seat it. And you'll notice there's 3 different keys here, and those are the chrome keys, which allow the stackable components to be inserted onto the fixation base. And so when we look at this clear guide, when we press down on it, if it doesn't seat, then we didn't take enough bone off. And so we have to then evaluate that for each time. Then we use our drills. And this again, here's an example from using the Megagen system. We're going to go in utilizing these special drills to create our drilling sequence one by one. And if you trust the technology, this becomes a very fast procedure. We can then place our implants through the guide, as I explained earlier, with our full template guidance. And then the key here is that we end up having the implants placed, placing the multi-unit abutments, and then placing the restoration, all in the same procedure. Similar to what we showed with the Tremblay article, this is now taking it to the next level. And so we have the technology to be able to do this. Here's a quick video here done with my dear colleague and friend, Dr. Isaac Towell. And we can see how all of these components fit together, the drill guide, the bone reduction guide, extracting those teeth, and then finally torquing the implants into place. This is truly the state of the art, in my opinion, in terms of guided surgery applications today. We can control not just the trajectory, but the depth and the rotational timing, which is critical when we're using multi-unit abutments, and especially angled multi-unit abutments. And so we have a variety of different software applications that allows us to do this. This happens to be the R2 Gate software from Megagen. I also highly recommend using Blue Sky Plan software, which again is totally free. And we have to collaborate most of the time with laboratory technicians to be able to enhance our ability to diagnose and treatment plan properly. Because unfortunately, most clinicians are not taking the time to be able to learn the software. And that's where we need to use online sessions that help you plan the cases. And there are many third-party companies all around the world that are very helpful in being able to do this. I'm sure that Omid can talk about in his area in Iran. I know that some of my dear friends in Egypt, in Israel, in many countries, in the UK, in Africa, they all have centers, diagnostic centers that are now able to help with these processes. And where it becomes important is when we're trying to plan these cases and we're looking at utilizing our multi-unit abutments and placing implants at a tilted position so that we make sure that that screw access hole is coming out through the proper position, and having the software that's able to do this really critical to that success. And not all software is capable of doing this to the degree where we can achieve the exact positioning of our components, both surgical and restorative. And so that's where it becomes extremely important for us to be able to concentrate on that so that we can have results where we can position implants, where we can position our multi-unit abutments. In this case, we use CAD/CAM abutments and multi-unit abutments to do a full arch FP1 type full restoration in the maxilla. And these are the type of restorations that we can achieve. We want to achieve soft tissue stability with our cases. We want to have, immaculate tissue when we can. And this is all because of our excellent planning. And can we do this without pink? Absolutely. And this is the type of results that we can and that hold up to the test of time. And so here's one that's 2 years post-op. Wonderful article that was that appeared in Dentistry Today in September of 2019 with my dear friend, Dr. Isaac Towell. We did several follow-up articles, and we can certainly make that available to the viewership that you have with your group. And so I think we're probably around the timing that we wanted to achieve, and maybe I can go to our conclusions here. Give me a second. So one of the other terms that I've coined in the literature, and by the way, here's a couple of articles from like 2009 and 2007. It's not the scan, it's the plan. And so it truly is not about taking the scan, it's about how much time we apply with our knowledge to understand what the capabilities are within the software and the imaging technologies and the intraoral scans that we will use. 3D printing today is really changed the face of what we do, and that really truly is a game changer as well. So what can we do? I believe we should always use cone beam CT to assess our patient anatomy. We should always understand the cortical plate thickness and crestal height, bone density, and opacity. The cone beam CT tells us to do. Use implant stability quotient to determine implant stability, as well as use 3D printing to enhance our diagnostics capabilities. Guided surgery is not just for implants. I didn't have time to show some of the most interesting things that we're doing, but maybe in the future we can do that with sinus grafting, with harvesting, all sorts of different wonderful modalities that we're using. But of course, more education and more training is needed. So I really appreciate the time that I got to spend with you today, Omid, and I'm happy to have some time to discuss these points with you.
Thank you so much, Scott. Wow, wow, wow. First of all, I knew it, but really looking at the numbers, the years that you showed, the articles that you brought to the world of history, amazing. You talked about so many of these new concepts that we are talking, back in 2000, back in, 1990s. And it's really amazing to hear things from a guy like you. So I'm so thankful for sharing it with us. And I noticed many interesting points in the presentation. Especially, I want to start off with the case you presented in the anterior mandible, the very first case, the 84-year-old lady that lost a central incisor, if I remember. And one of the things that I wanted to know your comment on that. With digital technology, now that we are able to exactly identify the trajectory of the bone and to exactly place our implant in a way that we want, no matter if it's freehand or with the guide. Is the depth of placement crucial for the final outcome we are going to gain? For example, the case that you showed, and it was beautifully restored, you know, the patient had like perio problems or bone loss, maybe up to, I mean, to the only 1 to 2 millimeters of the apex of the tooth was in the bone. So the patient has lost like maybe 8 millimeters of bone. And as I remember the digital planning, you place the implant at the level of the available bone. So it means that the remaining part was restored by the height of the abutment. And the case was beautifully done. So my question is that with knowing exactly where we want to place our implants, is the depth of implant placement still a crucial part in achieving the best results possible?
I think that's a debatable question be, based upon the implant system that you're using. And so, as we know, over the course, and I placed my first implant in 1982. So we've had a lot of changes since then, and since Brannemark, and since the Corvent days with Dr. Nisnik, and we've had all sorts of different designs, internal hex, external hex. When we went from the external hex to the internal hex, we had a different concept of the platform of the implant. When we went from an internal hex to a conical connection, and we went from a flat top type of connection of the prosthetics to a platform switch design, that changed the ball game quite a bit, in my opinion. And so if you have a platform type switch or shifting type implant design where the abutment is going to be narrower than the platform of the implant, then you want to place those implants deeper. That's what you want to do. And then oftentimes you will get bone growing above the implant platform and up the abutment itself. And so it truly is remarkable that we can maintain that. And certainly if you look at the original research done with the ankylose implant, as I believe the first true platform switch implant, meaning that the design of the implant itself was combined with the abutment design. So the of course, when Richard Lazara made his first publication on platform switch, it was kind of accidental, placing a narrower abutment on a wider platform because that's what they had. But today it's purposely done, and with it's the other part of the equation is the stability of the connection. The stability of a conical connection is tremendous. And so we have no rotation, no tipping, no mobility, and that enhances the ability to have a successful outcome.
Yeah, yeah. And you know, you talked about the triangular of bone, and you always talk about it. It's truly amazing. And you showed uh, two like animations about placing the implant exactly in the way that they should be. So when we are talking about retain versus a screw retain implant placement, if we want to place our implant in a screw retain fashion and place the platform under the, for example, in the anterior zone in under the cingulum area, you showed us that we can, instead of placing our implant this way, we shift and we rotate the implant, bring the apex of the implant toward the buccal and the platform of the implant toward the palatal. So what is the difference between this type of positioning or bring the implant completely bodily to the palatal? Is there any difference or for a screw retained implant placement in the anterior zone?
It really depends upon the available bone. And so when we look at the alveolus and we draw that triangle, we can see whether or not we need, well, first of all, we can see the topography. We can see if there is a concavity on the facial or the buccal aspect. And that concavity is what's going to be crucial to where that implant moves to the lingual or to the palate. And so when we have the assessment of the volume there, when we move the apex of the implant towards the buccal, we want to make sure that, of course, that we're not perforating through the facial plate. And in many cases, we will graft at the same time.
Mhm.
And so today, you got to remember, when we first started doing implant dentistry, we didn't have the variety of abutments that we have today, the angled abutments, multi-unit abutments, etc. And so when we can plan for the use of the angled abutments, especially angled multi-unit abutments for screw retained, we can play around as the architects and the engineers. If we were an engineer, we would be able to do that, on the computer and play around with, how things emerge. And that's exactly what we do on our cone beam CT. And so if you have more bone palatally, certainly you can bodily place the implant towards the palate. If you don't, then probably you'd want to angle it with the apex towards the buccal and then the coronal part towards the palatal. And most likely you would end up in many cases with a buccal concavity that will be grafted either with bone or soft tissue, not to support the implant, but to support the ultimate emergence profile. So you create a root eminence. That's what we want to create as especially in an FP1 type of restoration where we have no pink.
Yeah. So speaking of that positioning, sometimes some design of implants like coaxial implants uh, can solve the problem. I mean, my main concern usually by bringing the apex of the implant toward the buccal is that definitely I will have thinner bone in the area or maybe the risk of perforation. So definitely I should do some grafting in some cases. But comparing different designs, I want to know what's your thought about coaxial implants, especially in the aesthetic zone, that the trajectory of the bone most of the time is difficult to place them in a way that we want them to be. And from the aesthetic point of view, how do you
Well,
compare those designs with current design with different systems?
right. Well, first of all, the coax implant was actually the first implant that was designed in that fashion, and then the Astra Corporation kind of copied it with their implant design. And so there's two that have kind of that off angle. And when coaxes first came out, they actually did come to me many years ago because the concept was to, if you think about it, to make the coaxial implant work, the implant has to be placed exactly in the triangle bone concept
Yeah, yeah,
so that you will bisect the triangle, have the most volume of bone. And through all of my papers and my research, I've always said that correct angulation would be about 10 to 12 degrees if you use the triangle bone formula. And so the coaxial implant fits that perfectly. The problem that I had when I first used the coaxial was that they didn't have the type of connection that they have today. And therefore, they also didn't have the tooling, the instrumentation that was proper. So we had a lot of difficulty rotating the implant into the exact position that we needed to emerge through the envelope of the tooth. And so if you wanted to tweak it, and then you'd have to rotate it a little bit, you'd have to put the carrier back on, and it was difficult to visualize. I think they've changed that quite a bit. I know Dr. Stephen Chu likes to lecture quite a bit, and he does mention the triangle bone concept in his presentations. And so, is that a design that works? I think it's very, very important to take advantage of the most volume of bone, and that type of design does that as long as you can control that rotational position. And the only way that I think you can do it routinely and accurately is with doing it guided. And at the beginning, they when I was dealing with the company, they were not looking to do it guided. So we parted the company a long time ago, and we've never really had a discussion since then. But I do appreciate the design both that Coaxis has. I don't know how Astra was able to get the patent through Robert Cottrell, who had the original patent, Richard Cottrell, and because it seemed like it was based upon the coaxis design.
Yeah, yeah. Scott, you showed a beautiful case. It was in the maxilla, and you said that instead of extracting all teeth, you decided to keep some of them and place implants in between in some key positions and do the grafting for coming back again and extract the others and place the extra amount of implants, which I believe is a very wise choice because with that, you exactly know where to place your implants and how to plan the case. But I want to know, why did you decide to place your implants in two different stages? I mean, for example, because now you know exactly where are the position of the tooth. So it's possible to make a guide before extraction and then do the extraction, grafting, and come back, for example, 6 months later and use that initial guide and plan your implant positionings. Why you decided to place some implants at the first stage and keep some teeth and come back again and extract other teeth and place other implants? I mean, in two different stages.
Well, remember I said if you ask two dentists, you're going to get at least three different opinions. So we always have a different way of looking at the cases. And so when I looked at that case, the patient was kind of anxious and wanted to get everything done. Unfortunately, as we know, oftentimes the bone isn't there, and so we have to regenerate the bone, and so that takes time. The implants themselves, if we can get the implants there, I believe that they also can help to maintain as a scaffold as well, the surrounding bone, because in the interim, the patient's going to have to wear some sort of a prosthesis. Now, in many countries, you can tell the patient to walk around without teeth. In the US, it becomes difficult, especially a woman. And so knowing that she was going to have a denture, and so I wanted to help avoid too much compression on the graft. And so I elected, in the sites that we could place implants, to place the implants, graft all of the other sites. And then we're in the middle of that case. So when she comes back, probably in about another month, we'll uncover the implants. We'll be able to put locator attachments or some denture attachments on top of it, place the other implants, and then protect that site totally. And so that's the rationale, is if you can place in strategic positions, you can come back later to protect the sites by putting denture attachments on top of that for the interim during the staged approach.
That was a great. I mean, I learned a lot from the case because a different way of thinking. So I never thought about it that way to prevent the pressure on the graft and to manage some things with such kind of patients. So that was a great point to mention. And your topic is very interesting. I think we can talk about it for hours, but I really don't want to take your time more. Just one last question. I want to know actually an expert opinion from a guy like you. When we have CBCT, we can plan in so many ways for giving our patients their future teeth. And we know that crown to implant ratio is completely different than crown to root ratio. We know that, with different designs, we can manage things with different trajectory of bone. So do you think if you wanna, I mean, we can have different scenarios, but generally speaking, do you think that some dentists are doing over treatment in their planning for the patient? I mean, in many, many cases, we can place our implants with simple reduction or without any grafting. On the other hand, in many cases, we can do so many grafting and make everything look like perfect. But, it's the dentist's choice to choose which way they want to go. Do you think that we are facing over treatment in the patients in implant dentistry?
It's a great question. And I think that there's, as you said, there's a variety of different circumstances. The reality though is that when you truly are a student of 3D imaging and the technology that we have, you realize to a great extent what you can do, what you can't do very quickly by looking at the available bone, by looking at the bone density. I mean, I have plenty of, cases that come to me for second and third opinions. I have cases where the people have done huge full arch restorations, and then 2 weeks later, all of the teeth fall out, all of the implants come out with the prosthesis. And I can almost 99% of the time, I can go back to the scan and do a forensic analysis and determine that the diagnosis was incorrect from the beginning. And so if we learn to diagnose properly, we would then obviate the fact of overtreatment, because I think sometimes we overtreat because we are not sure. We're guessing about the overall success, and we say, okay, well, we'll put 2 or 3 extra implants in, or we'll do all this extra grafting, when it may or may not be necessary. So I think that the more education that we have, and understanding that every patient that walks in the door is different anatomically, in their way of being able to heal, in their occlusion, in their aesthetics, in their aesthetic values, and in everything that they in terms of their appearance, and what their own desires are. And once we understand that we have the tools to be able to assess to such a, when we first started using CT, got to remember back in the mid 1980s and then the early 1990s, before we had cone beam, which did not become available until around 2000. The average slice thickness that we were dealing with was 3 millimeters. That's what we would get from an imaging center, 3 millimeters. Today, on my cone beam CT, I'm using 0.125 on most cases, 0.125 millimeters. The accuracy is incredible. And so if we understand what we're dealing with from an anatomical standpoint and a restorative standpoint, I think a lot of the complications that we have are because people, they put the implants in, but they didn't figure out the prosthetics until later. And that's where we make mistakes and failures occur.
Yeah, absolutely right. Scott, thank you so very much for your kindness, for accepting the invitation, for sharing with me and so many dentists around the world during this time. And hats off. Really looking forward to see you very soon. God bless you. Stay safe and miss you so much. Thank you.
And we're always in that search for the black rhino. So we'll keep that going.
Yeah, thank you so much, my friend. Take care.
It's my pleasure.
God bless you. Bye-bye.